Welcome back to Healthy Living. We're talking today about UroNav, technology that helps physicians and St. Tammany Health System to diagnose and treat prostate cancer for men. We talked first with Dr. Joshua Sleeper, local urologist, about the importance of screenings and what patients can expect when they first encounter a PSA test and then the need for a biopsy. We talked about the UroNav system from the urologist perspective, and now next we're going to be looking at it from the standpoint of the radiologist. We have Dr. Joshua Yellen with us today, a local radiologist who works with St. Tammany Health System in the radiology suite. Good morning, we're glad you're here.
Good morning, thanks for having me.
Thanks for coming out. So we are talking today about prostate cancer, and as I mentioned, we talked from the urology perspective in terms of what the patient and the doctor are encountering in the doctor's office, but then once we've done a biopsy, we've got imaging that needs to be read. And so can you talk a little bit from the radiology perspective about where you come into this process?
Absolutely. So in the history of prostate cancer diagnosis, MRI typically played a pretty minor role. In the past, MRI was mainly used once the cancer was bad. And we were trying to figure out how bad it was, had it gone outside the prostate and was it starting to metastasize. But its utility as a diagnostic tool was actually pretty low. About 7-8 years ago, that started to change. We developed much better technology for imaging the prostate, and we started to figure out that there are other things about prostate cancer we can image other than just the architecture of the lesion that would help us make a determination whether or not this was cancer or not.
Wow. And
so the evolution of that slowly over the past little less than a decade got us to the point that we are at now, where we can produce a study called a multiparametric MRI of the prostate, multiple parameters. So we not just look at in great detail the architecture of a lesion, but we look at other factors that we know are associated with cancer, and the end result of that is a score that we can then assess each individual spot or question. And that's a pretty accurate way of diagnosing prostate cancer just based on the imaging alone.
That's pretty fascinating. So previous to this use of MRI, you're saying that it really was only once things were bad and we were maybe even thinking it was beyond the prostate that we would even consider an MRI. And this takes it a little earlier in the process.
Absolutely.
So can you talk a little bit about what the UroNav brings to that process?
So the UroNav is the second step in this process.
Okay.
The first part is getting the MRI and getting it done on a piece of equipment that can produce a high quality study, and then of course getting into the hands of a radiologist who has some experience. I think what was alluded to before is that this is really the first time that the urologist and the radiologist work closely together on each individual patient. So it's a two-step process. The first process is get the MRI, and then we can look at each individual lesion, if there is one present, and determine the likelihood of that being cancer. The second step is the UroNav process. We'll take the images, we'll turn it into a three-dimensional model, and then using a computer, I'll be able to identify a questionable cancer, create a three-dimensional model of that, and then send that information over to the urologist. He can then use that and map that onto the ultrasound in real time, and so he can see the MRI and the ultrasound images at the same time when he's going for a prostate biopsy.
Oh, wow. So essentially you're able to get imaging that really gives a three-dimensional real view of what the concerns are, and then you and the urologist together can make those decisions about what you're seeing and what needs to happen.
Yeah, it's pretty astonishing technology. In pretty standardized and in the past, what you would do is you would just use an ultrasound. An ultrasound can show you big aggressive cancers, but it's not very good at showing you smaller cancers or cancer in the earlier stages. And so the way that was dealt with is you would create a template, and urologists would just biopsy a set distance apart from one another and cover the entire prostate. And the assumption was that if we took enough biopsies, we'd get every part of the prostate and we'd find a cancer if it was there. With this advanced type of imaging, while we still do some templated biopsy,
sure,
you have an idea of where you're targeting. And that makes all the difference in the world, because now you know precisely where you're going to go, and we can grid that down to a matter of a couple of millimeters. And so like you said before, it is very much like a GPS process. It's a targeting system to find a lesion of concern.
Okay. So without the UroNav, we were sort of blanketing the space to a certain extent, figuring full coverage, we'll find it. And what this does is give us more certainty because we're able to really hone in and target we talked about GPS or bullseye as a way to say that we have more confidence that where we are biopsying is the area of concern.
That's exactly correct.
Okay.
And the other thing too is you think about it, when you're taking biopsies in the prostate, you're limited by how far apart you space those biopsies. And the only way to change that, especially in a big prostate, which as men get older, their prostates get bigger, is to take more biopsies. And so, by the very nature of the process, if you really want to cover the prostate and find smaller lesions, let's say smaller than a centimeter, you have to take a lot of biopsies and cover the whole prostate. Theoretically, this process allows a surgeon to take less biopsies because they know where they're going.
Gotcha.
The other upside to this is that, let's say you do the biopsy and it comes back negative, but the MRI is very strongly positive, and depending on your score, we can be up to 90–95% sure that it's cancer.
Wow.
Well, now you've got a discordant biopsy result. And so we have to go back and say, something's wrong. We need to do another biopsy, or we need to find some other way to reconcile the two different reports. So it not only allows us theoretically to take less biopsies, it allows us to be more precise in targeting and also more accurate in our diagnosis.
Fantastic. So essentially this piece of technology is enabling you as the radiologist and then Dr. Sleeper or his colleagues as a urologist to have much more confidence in the data, to have a sharper picture, if you will, of what's happening there, and therefore to make diagnoses and treatment plans for how we're going to beat that cancer.
Absolutely. If the patient comes in, like you mentioned before, with an elevated PSA, and their prostate is completely clean, I can say with a very high degree of certainty, probably more than 90%, there's no cancer there. So then Dr. Sleeper can be confident in telling his patient, hey, no cancer, we're still going to watch you, active surveillance, but we don't have to worry about this right now, and everybody feels a little bit better. If we see a cancer, and for whatever reason, it's not noted on biopsy, we know we have to continue following this patient very aggressively or do something else. So it not only gives the patients the confidence of knowing they don't have cancer when their MRI is negative, but it allows us to monitor them a lot more closely if there is a questionable finding there, if it's a positive study.
Wow. So thinking about when we spoke with Dr. Sleeper this morning, we were talking about how a patient will see that PSA number, and that PSA number is rising, and as you said, as men age, the prostate enlarges, and so those things are concerning to that patient, and they want to see what's being done and how to protect themselves or how to fight cancer if it's there. And what you're saying is this is giving us even more concrete information that is much more specific and data-driven, and it enables you and the urologist to put that treatment plan together that's much more effective.
Yeah, I mean, for the first time in sort of medical history, we're allowed to look inside the prostate now, which is a very difficult organ to image. At least it has been up until 8 or 9 years ago. So nothing beats being able to see the architecture of the prostate. That is a direct visualization of a potential problem, as opposed to in the past where you just had secondary indications. The PSA is going up, there's a nodule that I feel, I'm having symptoms. Those are all secondary signs. Now we can actually look inside the prostate and say, oh, we see something that's concerning.
Outstanding. Well, visualization of the prostate and of the disease sounds like we've introduced some important technology. Dr. Yellen, I appreciate you coming in to talk with us about the radiology perspective of UroNav.
Appreciate it. Thanks for having me.
Next up on Healthy Living, we'll be talking with Kim Belsom. She's an ultrasonographer with St. Tammany Health System.